Test, test, test. Maddie, can you hear me? Can you hear me, Maddie? Oh, she's connecting. Okay, you can hear me. All right, good. Okay, Maddie, are the slides moving?
I can see the slides.
Are they moving?
No, they're not.
They're not? Okay.
No.
Okay, now are they moving?
No.
No? Are they moving?
No, they're still not moving.
Okay, then. Now they're moving?
Yep, they're moving.
And that's what we'll do. For the life of me, I don't know why that doesn't work. Who can tell me which has better bioavailability, fractionated or low molecular weight or unfractionated heparin? And yes, I'm struggling with a cold, so I'm trying a new voice out today. My wife votes for it because she thinks it's sexier. Anybody? Nobody wants to take a stab? Which has better bioavailability? Low molecular weight or unfractionated heparin? You guys on Zoom, you can chime in too if you want.
Is it low
Bree-
molecular weight?
Yes, Bree is right. Low molecular weight heparin. Low molecular weight heparin has better bioavailability, has longer half-life, more predictable pharmacokinetics. How is heparin administered? Is it oral? No. I see Caitlin shaking her head over here. How's it administered? I can't hear you. Subcutaneous injection. Subcutaneous injection, very good. What's the antidote for unfractionated heparin? Protamine sulfate, very good. Protamine sulfate. How does unfractionated heparin work? What's its main target in the body? Sorry? Clotting, yeah, how? What's its target? Fibrin? No. Fibrin production. Say it again, Bree. Bree, when you speak, you go in and out. So it's hard for me to understand you. Can you hold the microphone close to your mouth and say it again? I'm sorry, Bree, I just can't understand you. Antithrombin 3. Antithrombin 3 is the main target. Is that what you said, Bree?
I was trying to say factor 10.
Oh, okay. Antithrombin 3 is the main target for unfractionated heparin. For low molecular weight heparin, the main target is factor 10. Factor 10. Because it's the longer polymers that attach to antithrombin 3 in heparin. Because low molecular weight heparin is just the smaller polymers, their main target is factor 10. So we're going to talk today about the one really severe side effect of heparin. This is not common, but you have to watch for it. I have a student in one of my nursing classes who's a nurse extern. She's actually seen this before. So it's common enough to that if you are around hospitals, you will see it. This is called Heparin-induced Thrombocytopenia, which is mercifully abbreviated HIT. Who among you can tell me one of the advantages of unfractionated heparin? It's easier to reverse because of the antidote. Yes, that's an advantage. Protamine sulfate does a lousy job of reversing low molecular weight heparin, but with unfractionated heparin, it's pretty much 1-to-1. What else? Not excreted by the kidney. So you don't have to adjust it for people with renal disease, whereas you do with low molecular weight heparin. Okay, getting back to heparin-induced thrombocytopenia. Heparin in some people will form a complex with a protein found on the surface of platelets called platelet factor 4. PF4. This heparin PF4 complex is viewed by the immune system as foreign. So the immune system will mount an immune response against this heparin platelet factor 4 complex. And these antibodies can bind to the surfaces of platelets. When they bind to the surfaces of platelets, they activate the platelets. And they activate the platelets en masse. So you get two things that happen when you have heparin-induced thrombocytopenia. You get blood clots everywhere, all over your body, and then you use up all your platelets so that you are now at risk for bleeds. So typically you have deep vein thrombosis, the very thing heparin is meant to prevent. And you can also get pulmonary embolisms. So with deep vein thrombosis, you're going to have swelling and discoloration of the limb. The most common place where you see deep vein thrombosis is in the legs usually. It is tender, it's warm to the touch, veins will stick out because the vein that has been blocked, blood gets diverted to other veins. So the other veins literally are really full and they tend to just kind of bulge out. Once you've seen this, you'll never forget it. You can't miss it pretty much. Also the area. So wherever you have the block, the area below it is usually really red, and the area above it is kind of whitish looking. With pulmonary embolism, you get shortness of breath, you get a change in heart rate, and that change in heart rate can be abrupt sometimes. Dizziness and sharp chest pain, especially when you breathe in, because that breathing in involves expansion of the chest. Because the clots tend to occur in the periphery of the body, distal limb ischemia is really common with heparin-induced thrombocytopenia. So you can see in this picture here, this poor individual has clots in the small vessels of the hands and also of the toes. It's not unreasonable to think they're probably going to lose some of those toes in that case. If you see this sort of thing in a patient on heparin, so some of you will be PTs, your patients coming in, they might still be on heparin in some cases. You should get a good look at hands and toes. If you see something like this, that's an emergency. You call the ambulance right away. You get someone after a limb replacement, you should look at fingers and toes. You see that, that's an emergency. You want to keep that limb, you call the ambulance and you tell them you need to get here about as fast as you can. And you might have some of these other signs or symptoms as well with DVT or PE. So again, you get these antibodies, they bind to these complexes on the surfaces of platelets. These complexes consist of heparin and platelet factor 4. The antibody has a piece at the end of it called the FC region. That FC region binds to an FC receptor on the surface of the platelet. When it binds that FC receptor, it activates the platelets. So the platelets just kind of go gonzo schizo activation. You get this en masse activation of platelets. And this picture here is meant to show you, no, I didn't draw this, I stole this from someone. Show you how this essentially works. So PF4, again, is a surface protein. It can be shed into circulation. Heparin will make a complex out of that. You mount an immune response to it. These antibodies will bind to it. And then because PF4 is also on the surface of the platelet, when the antibody engages the heparin PF4 complex, that piece, the FC receptor, the FC piece, so this is called the FAB piece, of the antibody. This is called the FC piece. It's called FC because it crystallizes if you isolate it. So it's called F sub C. This piece binds to the receptor here that activates the platelets. Because you burned up all your platelets, you get so-called thrombocytopenia. You don't have any platelets. Fortunately, when you draw blood from someone in the hospital, measuring platelets is dead easy. You send it to the lab and they drip it in the machine and they push a button. It takes all of 5 seconds and they can count platelets. If your platelet levels are below 150,000 per mil, that's low. If it's below 100, that's really low. If it's below 50,000, that's extremely low. So if it's below 50,000, that's, red alert essentially. Or, Lost in Space, Danger Will Robinson, whatever your signal is. So you activate the platelets and you get clots everywhere. That's the contradiction. You get lots and lots of clots, and yet you've burned up all your platelets. You can't make more clots, so you could theoretically bleed to death. So the clots are causing stuff like this, but you can still bleed to death because you've chewed up all your platelets. So how do you treat this? You don't want to give heparin, obviously. So the two main drugs that you can use to treat this is the second drug here, argatroban, and on your list of medications, there are some medications for heparin-induced thrombocytopenia. Yeah, here we go. So page 88, it says for HIT. So argatroban is probably one of the main drugs that's given for HIT. That's to prevent the activated platelets from forming these new clots. The other drug that's used is bivalirudin. Bivalirudin is a drug that was developed because people took leeches and they analyzed the anticoagulants made in their salivary glands. When a leech latches onto you, if it starts to suck your blood, that blood's going to clot and the leech is going to get plugged and the leech isn't going to get its breakfast. And the leech is greedy, it wants its breakfast. So its salivary glands make these really powerful anticoagulants. And so people started doing some molecular biology on the leech. In fact, when I was at Sussex University as a postdoc, there was a French dude there who was working on this project. I still remember him. Gosh, the guy I think was this tall. He spoke fabulously good English with a very strong French accent, of course, but perfectly understandable. And this was one of his projects, was he was trying to clone the genes from the salivary glands of the leech that were involved in anticoagulation to potentially use these in medicine. And lo and behold, there were 3 drugs that were generated from this. Of these 2, desirudin and lepirudin have been withdrawn because people tend to get allergic reactions to them. But bivalirudin is the one that remains. And argatroban and bivalirudin are the 2 that are used. And then fondaparinux is used off-label. So these other 2 are used, they're FDA approved for it. Fondaparinux is used off-label for HIT. So again, this sort of thing will usually come up 5 to 14 days after heparin is given. So that's your kind of zone you're looking at. Once they've started heparin, 5 to 14 days, if it's outside that particular zone of time, the chances that it's hit is not very high. So if you have antibodies to PF4 in the blood, that is pretty much regarded in the medical world as diagnostic for HIT. So if we just take a little scheme here, let's imagine, say Dr. Jones over here. Say Dr. Jones has a patient and that patient has just come out of surgery, and Dr. Jones, let's say, is a hospitalist. So she's an ICU person. Usually they specialize in internal medicine. So let's say Dr. Jones is an internalist, but she's working in ICU. She's a hospitalist. Patient comes out, say the patient's had a hip replacement, and they're not yet on oral anticoagulants. They've been on heparin. They're being given heparin before they go home. And they got an infection, so they have to stay in the hospital a little bit longer. Well, depending on the infection, maybe a lot longer. So the patient's had intravenous antibiotics. Say it's been about a week since they started the heparin, and Dr. Jones goes over and looks at the patient, pulls up the blanket, looks at the toes, and starts to see not blackening, but maybe some bluish color in the toes. So, Dr. Jones, what blood test you going to order? The tests, maybe. What blood tests you going to order? These old years don't hear. Okay, yeah, exactly. What tests are going to tell you that someone might have hit? What tests? Okay, so you pass it off to the nurse. So you tell the nurse, this patient might have hit, but why don't you do a draw and then send it through for the typical hit test. So the nurse over here, nurse, what test do you tick on the box to the lab? You're not sure? Oh man, our patients are deep leads here. Okay. Number one, the platelets, if the platelets take a dump, the thrombocytopenia means lack of platelets. That's what it means. Thrombocytopenia means lack of platelets. So you're going to measure platelets. So that's the first box you're going to tick. What's the other box? What's the other thing that's diagnostic for HIT? Antibodies against PF4. That's the other box you're going to tick. Is the anti-PF4 box. And fortunately, there are good commercial tests for antibodies against PF4. So you tick those two boxes. If the platelets are really low and PF4 is positive, patient's got hit. And research has shown if you catch this early, the prognosis for the patient is much better, much better. So Dr. Jones, you know what test you're going to run now? Okay. And the patient survives. Good for you. All right, you ready for the world's biggest pain in the butt drug? Warfarin. Warfarin is an indirect inhibitor of coagulation. It prevents this very important modification of these clotting factors after they've already been synthesized. So warfarin is going to have a slow onset of action. It takes 4 days for warfarin to start working. 4 days. Therefore, if you start someone on warfarin, you have to bridge them with another anticoagulant. Always, 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 always. Now you're probably wondering, well, gee, if warfarin is such a pain, why is it still used? There are some things for which you can only use warfarin. 2, warfarin is dirt cheap. A month's supply of warfarin, what you'll pay for it is less than a penny per pill. It's very inexpensive. Three, there's a lot known about warfarin. It's been used extensively. It's well understood. Problem with warfarin is that it varies wildly from patient to patient because it's influenced by your genetics. It's influenced by your health status, and its activity is influenced by your diet. So you have food-drug interactions, drug-drug interactions, genetics-drug interactions. So warfarin has to constantly be monitored. That's why it's such a pain. So clotting factors 2, 7, 9, and 10 have to undergo this post-translational modification. This modification occurs in the liver. Now, warfarin, fortunately, is taken orally, and it's very effectively absorbed. It's 100% absorbed. So it has excellent bioavailability. It is also very strongly bound to serum proteins. And the response varies. And it works largely as a vitamin K antagonist. Vitamin K antagonist, that's how it works. So it's indirectly acting. Therefore, if you want someone to have some control over an out of control clotting system, you can't just give them warfarin and expect it to work right away. It takes time for it to start working. So here's how warfarin works. In the liver, you have these two enzymes. They're called VCOR and VKDC, and they recycle this vitamin K cofactor. So VCOR is the vitamin K epoxide reductase. And as you can see, when this cofactor plays a role in modifying the clotting factor, it gets converted into an oxidized form, which is an epoxide. So the VCOR enzyme, the vitamin K epoxide reductase, is going to reduce the epoxide back to the reduced form. It regenerates it essentially. Warfarin inhibits VCOR. It inhibits VCOR. Because you don't regenerate it, the reduced form is not available for the modification of the clotting factor. Now, here's the first part where genetics makes a big difference. Turns out that the gene that encodes VCOR, the VCORC gene, is highly polymorphic, varies tremendously from person to person. And it encodes an enzyme that is inhibited by warfarin variably from person to person. So that's number one when it comes to variability of warfarin response. It depends on your VCOR enzyme. Some people have a VCOR enzyme that's very effectively inhibited by warfarin. Others do not, and they need more warfarin for it to work. Now here's the other piece. Here is the half-life of the different clotting factors that are modified by that vitamin K dependent reaction. You have to inhibit all four of these in order for it to work. Notice that clotting factor number 2, which turns out to be thrombin, has a half-life of 100 hours. That's 4 days. That's why it takes warfarin 4 days to start working. Another piece about warfarin, you might find this not terribly interesting because it's of a chemical nature, but warfarin comes in 2 different stereoisomers. So the drug you take is a racemic mixture of the R and the S form of warfarin. The R stereoisomer of warfarin inhibits the VCOR enzyme, but it does so weakly. The S stereoisomer of warfarin inhibits VCOR rather strongly. The S stereoisomer is metabolized by cytochrome P450 2C9. That's the major cytochrome P450 that metabolizes warfarin. Consequently, drugs that inhibit cytochrome P450 2C9 or induce cytochrome P452C9 are going to affect the pharmacokinetics of warfarin. Cytochrome P452C9 is itself subject to extensive polymorphism within people. Therefore, some people will metabolize warfarin robustly. Others will hardly metabolize warfarin at all. That too contributes to the variability from patient to patient. The R stereoisomer, as you can see, is metabolized by multiple enzymes. So it's not so much of an issue. If you inhibit one enzyme, the other enzymes can pretty much metabolize it. Warfarin also, its activity is affected by the amount of vitamin K in your diet. It turns out that there are bacteria in our GI tract that make vitamin K. Babies don't have those bacteria. So when babies are born, before their first 6 months, they're usually given a shot of vitamin K. And if any of you have little brothers and sisters, if you either got to be there or got to go to their doctor's checkups, they might have been given a shot of vitamin K. That's standard fare in this country. What sort of foods are rich in vitamin K? So if this wasn't covered in your nutrition class, let's talk about this right now. So the biggest vitamin K content per cup is spinach. It has 889 micrograms of vitamin K per cup of spinach. That's a lot. Next is mustard greens. Mustard greens. Now, when was the last time you put mustard greens on your salad? Yeah, check that box that says never, essentially. Collard greens. Now, I've had collard greens, and I like collard greens. Those are also very high in vitamin K. Beets, quite high in vitamin K. Dandelion greens. Who eats dandelion greens? What are we, cows? They're quite high in vitamin K. Okay, I'm not trying to offend you. Does anyone here eat dandelion greens? I didn't even know that was a thing, but Swiss chard. Now, I have had Swiss chard. Swiss chard is actually quite good. That's very high in vitamin K. Turnip greens. Garden cress. Now, here's one you've probably eaten, kale. Quite high in vitamin K. Brussels sprouts. Those are really good if you bake them. If you bake them, you get them in charcoal, just a little bit. They're very high in vitamin K. Broccoli. Now that's enough. Come on, you've heard of broccoli. That's high in vitamin K. Cabbage, pickles, okra, green beans, celery, and fennel. That's the order that's descending. So fennel has about 55 micrograms per cup, not quite so much as, say, spinach. Topping out at 889. So when you get on warfarin, you'll be given a sheet of vitamin K rich foods, and you'll be asked essentially to stay away from them. They ask you to eat as you would normally eat. If you change your diet, however, and you have more vitamin K food in it, all of a sudden say, I'm going to start eating healthy food, and you start getting vitamin K rich foods, it's going to affect your warfarin activity. So there's genetic drug interactions and food drug interactions. So warfarin has a long half-life. Its metabolism varies from person to person due to genetic differences in cytochrome P452C19. And it's affected by what you eat. It's also affected by your levels of anemia, liver disease, biliary obstruction, and other drugs that you are taking as well. Here's some drug-drug interactions with warfarin. Gang, this is a short list. The list is actually much, much longer. This drug interacts with lots of different drugs. So there are drugs that increase the prothrombin time. That means it makes warfarin work better. There are drugs that decrease the prothrombin time, meaning that it is going to cause warfarin to work not as well. So because of this, warfarin, if someone's on warfarin, you really have to watch the drug-drug interactions because the drug-drug interactions are extensive. Warfarin on the average is relatively well tolerated. The big side effect you need to watch for, of course, is bleeding. In particular, intracranial bleeds. That's probably the biggest bugaboo with warfarin, the intracranial bleeds. Some people say it gives them gas. Some people say they get a cold feeling. Fatigue, pale skin. Some people say it changes the way foods taste. Hair loss is experienced by some people. Bleeding, of course, and easy bruising. That's actually quite common. Severe side effects, of course, are GI bleeds. So if you see a condition called melena, that's black tarry stools. If there's vomit and you see kind of coffee grounds looking things in the vomit, that's clotted blood. That means you're getting usually an upper GI bleed of some sort. Swelling around the face and so on and so forth, that's due to an allergy to the drug. That will usually occur soon after you take it. Numbness, tingling in the body, priapus might be a problem in some cases. Joint pain, things like that, what have you. These are usually indications of more severe side effects, and the physician probably should be contacted under those conditions. Warfarin. Never, never, never give warfarin to a pregnant woman. It causes malformation of the face, causes malformation of the bones. If you start someone on warfarin and you don't bridge them, they'll get something called Coumadin-induced necrosis of the skin because it inhibits protein C, which is a natural anticoagulant. Protein C also undergoes this vitamin K-induced modification. Protein C has a very short half-life. So it's inhibited first. That's why you must always bridge people with another anticoagulant. Ecchymosis means you're getting bleeding beneath the skin. You'll see these large patches of bruising and blood. It's not uncommon for someone on warfarin, if they say they whack themselves or something, they get these large swaths. They will bruise very easily. They need to be careful. Also, anyone on warfarin, really anyone in any anticoagulant, particularly on warfarin, they need to use a very soft bristled toothbrush. And when they go to the dentist, usually the hygienist will stay away from the gums because sometimes you can just touch the gum and the gum will start to bleed. So the antidote for warfarin, fortunately, you can either use vitamin K. If you want immediate reversal, you can use something called PCC prothrombin complex concentrate. That's given intravenously. That will reverse it very quickly. You can also give fresh frozen plasma. Then giving vitamin K1, that will reverse the warfarin. That'll continue to reverse it, and then that can be given orally after they're sent home from the hospital, essentially. So warfarin has to be monitored and has to be monitored constantly. People on warfarin usually will need to get tests done at first weekly, and then maybe biweekly, and then maybe once a month. But they need to have their blood clotting tested constantly. So if you are testing blood of someone who's on heparin, unfractionated heparin, you'll use the activated partial thromboplastin time test, known as the PTT or APTT test. And we talked about this one, remember, play table tennis? So this particular test is used for the intrinsic pathway. Someone who's not on anticoagulants, this test should be, the result of this test should be between 30 to 40 seconds. If someone's on heparin, then you want that number to be 1/2 to 2.5 times the normal values. 1.5 to 2.5 the baseline. So if, for example, their number say was 30, then you want it to be 1.5. So 45, you want it to be between 45 and 75. That would be your range that you would want. So you want it to be somewhere between 50 to 90 seconds, something like that. That'd be your range. If their PTT time, if their PTT test ends up being something like 120 seconds, then you need to back down the heparin. If it's something like 45, then you would probably want to dose up the heparin. So with this test, you put the sample in a test tube. You take just the plasma will have the coagulation factors, and then you add silica or something that mimics the surface of a platelet. That will activate the intrinsic pathway. And then you measure the time it takes for the sample to coagulate. Again, you put it on this surface and then you close it and push a button, and when it gets opaque, the alarm goes off and it tells you the time. For warfarin, you're going to use the prothrombin test or the PT test. In this particular case, you're also going to take the calcium out. It says that my internet connection is there. Let's try that. You're going to take the calcium out, and then you add back factor 7, that adding back the factor 7 will essentially cause the extrinsic pathway to be activated. The problem, not factor 7, sorry, tissue factor. The problem is that the numbers you get with this test vary according to the kit you use. So you go to the computer, you download a program. It's called the PT standardization program. I hate colds. Gosh, I hate them. And then you tell them the kit you used, and then it gives you it standardizes a number, and you get a number that is called the International Normalized Ratio, or the INR. So your PT test is standardized to an INR. For someone on warfarin, the INR needs to be between 2 and 3. If it's below 2, it's too low. You need more warfarin. You're in danger of a clot. It's above 3, you have too much warfarin, you're in danger of bleeding to death. For people not on any anticoagulants, the INR is usually 1-ish. Between 0.9, 1.3, something like that. Some people maybe just above 1.3. But this is your number essentially that you're getting. You're getting the INR, and you have to do this test frequently to make sure the warfarin is at the right dose. Any question about heparin, warfarin, and these others? Someone has artificial heart valves, they have to be on warfarin. That's the drug that's FDA approved for it. Just the way it goes. Let's take a look at the newer oral anticoagulants. So if a drug ends in XA ban, it inhibits factor 10. So rivaroxaban was one of the first factor 10 inhibiting oral anticoagulants. It was approved by the FDA July 1st, 2011. And it really has become the mainstay in many cases for people who've just had hip and knee replacement. It is also used for prophylaxis, for stroke prophylaxis in people with atrial fibrillation. This drug is largely cleared by the kidney. Side effect, of course, is bleeding. Rivaroxaban is preferred over warfarin because you don't get the same number of intracranial bleeds that you do with warfarin. In fact, all of these drugs that we will talk about are superior to warfarin when it comes to number of intracranial bleeds. That's why many physicians prefer them. They also don't need monitoring. The second of these drugs is apixaban, goes by the trade name Eliquis. So this is Xarelto, Eliquis. This was approved just after rivaroxaban was approved. This drug has the lowest risk of bleeding of all the factor 10 inhibitors. This drug is only slightly renally cleared. It's mostly cleared by the liver. Therefore, this drug is preferred in people with renal dysfunction. Newer drugs in this group included doxaban, Savesa. This also prevents stroke in people with atrial fibrillation. This drug is 50% renally excreted. It is not recommended in people with end renal disease or people who are on dialysis. And then betrixaban is the newest of this group. So this is approved for people as a prophylactic against deep vein thrombosis in people with atrial fibrillation or folks who have had a knee replacement, hip replacement, something like that. This drug is not metabolized by cytochrome P450s, so it doesn't have any cytochrome P450 eliminations. It's completely eliminated by the kidney, so you have to adjust it for those who have kidney dysfunction. One of the big downsides of the new oral anticoagulants is that there was no antidote for them. Now there is. The FDA has approved this drug, Andexxa. So this is andexanet alpha. It is a dummy form of factor 10. So this dummy form of factor 10 binds to binds to the drugs and inactivates them. This drug comes like this. Essentially, you can either put this straight in an IV, or you can take it and just hang it on its own. Again, those drugs do not need monitoring. Neither does this one, dabigatran. Dabigatran is a direct thrombin inhibitor. This drug is also superior to warfarin in that it has decreased risk of intracranial bleeds. It, however, has increased risk of GI bleeds. So this is a drug known by the name Pradaxa. And if you take this drug with either simvastatin or lovastatin, it increases the risk of major hemorrhage, but not atorvastatin. So the big risk with this one is GI bleeds. There is a very good antidote for dabigatran, adagrasizumab. Adagrasizumab goes by the merciful trade name of Prexbind, which I think you'll agree is much easier to remember than isosizumab. Adagrasizumab is an antibody that binds to dabigatran and completely inactivates it, and inactivates it quite quickly, in fact. You don't have to adjust it for renal disease. It comes like this. It's ready to hang. In fact, you just take it, poke it, hang it, put it in the vein, and it works quickly. It comes in a box with 2 of these. You usually have to give 2 of these to completely inactivate the dose of dabigatran. So this is a humanized, adagrasizumab is a humanized antibody. Allergies to it are virtually unknown. So let me reiterate. These drugs that inhibit the clotting pathway, they are used in veins to inhibit clotting in veins. I know I've said that already, but I'm going to keep saying it because it's important that you remember that. Any questions about any of those drugs before we get to the antiplatelet drugs? Any questions from the crew on Zoom? Zoom crew?
I'm good.
You're good?
No.
No? Okay. Let's talk about antiplatelets. So your nonsteroidal anti-inflammatory drugs are going to inhibit platelets usually a little bit. Because most of your NSAID drugs are not, that they're competitive inhibitors of enzymes that activate platelets. They are short-term inactivators of platelets. The exception is going to be aspirin, because aspirin is a permanent inhibitor of the enzymes that activate platelets. So NSAIDs do decrease platelet activity. There are some other drugs that just not used that much. So they're thromboxane receptor antagonists. This one drug you see here, Seratrodast, is used in Asia. It's not used in the US. It's not approved. And this other drug, Teritrovan, that's not approved either. These are mainly experimental, so those aren't usually used. This drug, however, is used for Apexar, and this inhibits the thrombin receptor on the surfaces of platelets. So this is used to decrease the risk of a heart attack in people who are at risk for a heart attack. And these particular drugs have their efficacies. If you have someone essentially who's had some sort of procedure or something like that, and that puts them at risk essentially for some sort of clot that can get in their coronary arteries or something like that, these types of drugs essentially are drugs that can cause clots. And so Vorapaxar is a drug that prevents thrombin-induced activation of platelets. This drug is oral. So it's really quite convenient for that matter. So this is used for people who have a history of heart attack, and if they are at risk essentially for another one, because the coronary arteries are kind of beaten up. Your antiplatelet drugs don't cause as much bleeding as the anticoagulants. That's one of the upsides of them. They will still cause bleeding and increase bruising and so on and so forth. They may also increase the risk of skin irritations and rash. Some people report depression. It's not clear that the drug is responsible for that, but it's correlated with it. And then anemia too is a potential side effect as well. People will usually get this drug after they've had stents put in, usually. And this just shows you the platelet and thrombin activating the platelet. Vorapaxar will inhibit that particular receptor. Another drug that was developed alongside Vorapaxar is Atopaxar. Atopaxar failed in phase 3 trials, so it was abandoned. Now we come to probably the most heavily used group of antiplatelet drugs, and these are the so-called P2Y12 receptor inhibitors. So the P2Y12 receptor inhibitors bind to the receptor for ADP. ADP, you might remember, is an activator of platelets. These antagonize that ADP receptor on the surfaces of platelets, prevent them from being activated. So there are 4 drugs in this group. There's clopidogrel and prasugrel. These drugs bind irreversibly to the ADP receptor, the P2Y12 receptor. And then these other 2 drugs, ticagrelor and cangrelor, those 2 are prodrugs. They're not prodrugs. These will bind reversibly to the receptor. Both clopidogrel and prasugrel are prodrugs. They have to be activated by the liver first. Ticagrelor and cangrelor are not prodrugs. And cangrelor, as you can see, is given intravenously. Cangrelor has a very short half-life. It has a half-life of 3 to 6 minutes. So it's usually given during procedures. That's when cangrelor is given. The others are oral and are given usually when you leave the hospital. So the platelet has several molecules on its surface that help it work, that are involved with its activation, involved with its function once it's activated. And there are some ways, essentially, you can gum up the works, if you will. So we have these thrombin receptors, and we can use thrombin receptor antagonists. That's what Vorapaxar is. We also have this receptor here, this glycoprotein 2B3A. That is an aggregation receptor. We're going to see there's some drugs that gum up that receptor. There's this receptor here that allows it to bind the von Willebrand factor. That's glycoprotein 1B. There aren't any drugs that antagonize 1B that are used commercially, at least. They're used in the laboratory, but not commercially. And then you have drugs that are going to gum up the ADP receptor. And so that P2Y12 receptor there, that's what these drugs are going to come up, that ATP receptor, and they'll prevent the platelets essentially from changing shape and being activated and so on and so forth. So let's talk first about clopidogrel. So clopidogrel is used extensively after people have had a heart attack or a stroke. It is a very good drug. It's an older drug. There's a lot known about it, consequently, because it's been prescribed so much. Comes in 75 or 300 milligram tablets. Bleeds, minor bleeds are a side effect. Major bleeds are rare. The severe side effect is this condition called TTP, thrombotic thrombocytopenia purpurea. What causes TTP is still a bit of a mystery, but it's a rare but potential serious side effect of all the antiplatelet drugs. So with heparin, it was HIT. With the antiplatelets, it's TTP. This drug, unfortunately, does not have great bioavailability, and you get a pretty variable drug response with it. So once you put someone on it, you have to see how it's working. You don't want to give this to people who have some sort of active bleed. So if someone has some sort of stomach ulcer, intestinal ulcer, intracranial hemorrhage, you don't give this drug. Proton pump inhibitors are inhibitors of cytochrome P452C19. And cytochrome P452C19 activates clopidogrel to a prodrug. From the prodrug to its active form. So clopidogrel is a prodrug, is a prodrug, not poor drug, prodrug. If you don't activate it, it doesn't work. So you can't give it with proton pump inhibitors. Now, the literature will say avoid it with NSAIDs. The thing is, doctors prescribe it with aspirin all the time. So the caveat I'd say here, avoid use of it with NSAIDs would be unless directed by your physician. Because this drug is used with aspirin, and it's used with aspirin often. So this drug does not play well with proton pump inhibitors. Okay, looking at Mickey, it is 8:45, so that's the time for us to quit. We will finish this next time. And then we will get into pain relief. We'll start with the NSAIDs. Those are drugs all of you, I'm sure, have some experience with. If you've ever had a headache and you've taken ibuprofen, or ever had muscle aches and taken ibuprofen, you've experienced NSAIDs. Then after that, we'll talk about opioids, because all of you will have patients who are on opioids. So, very good. All right, gang. Thank you for attending on Zoom. Bree, have a good vacation, or I don't know if you're on vacation, whatever you're on. Enjoy your trip. Maddie, hope you're well soon. And I hope to see you guys soon.